Hi, you're diagnosed with psychogenic non-epileptic seizure. And the first question you will ask, can this be treated and how? And can this even be cured? Fortunately, the answer is yes, this can be treated. And now with better understanding of the underlying cause and how the psychogenic non-epileptic seizure happens, we have much better treatment that are evidence-based and really works for patients. And today you will learn how to treat PNES and how to make your doctor and your therapist much better at handling non-epileptic seizures and be the expert instead of going out to referral centers. This is the fourth video of a series on psychogenic non-epileptic seizures. And in the first three videos, I discussed what is psychogenic non-epileptic seizures and how we can make the diagnosis and what is the cause of non-epileptic seizures. And I will leave all the details and the links in the description below. The first thing when we make the diagnosis of PNES or psychogenic non-epileptic seizure, we should continue following the patient, and the patient should continue to follow with their neurologist. And it's not the practice that say like, you have non-epileptic seizures, you don't have epilepsy, good luck, and go see the psychiatrist. No, the patient should follow with their neurologist. The first thing, if they have only non-epileptic seizures without any evidence of epilepsy, to slowly come off and taper the anti-epileptic drugs, because that helps a lot to decrease the side effects and not be taking medications that you do not need. And that has been shown to improve the quality of life. And the second thing, you want to have a consultation and see the psychiatrist and the psychologist for treatment with medical therapy and with the psychotherapy as well, which we will describe in details now. So it will take a team to treat non-epileptic seizures, not just one doctor alone. There are two arms of treating non-epileptic seizures, and they are always followed in parallel together. The first one is therapy, which is usually cognitive behavioral therapy that has been shown to help a lot. And what happens is that CBT, cognitive behavioral therapy, gives you a tool to channel out the conflicts that we talked about in a healthy way that will not go into having a seizure. And sometimes when we start the treatment and the CBT, things might get worse before they get better, because we are opening the wounds and we are like going to areas that are uncomfortable to the patient to discuss and talk about. So sometimes getting those out can be a little bit stressful, and seizures can get worse, and then they will get better as you learn to master those skills and be better at dealing with them. It's kind of like pulling a tooth or pulling a spike out of your hand. It will hurt a little bit while it's coming out, but once it's out, it really is a relief. So CBT gives you tools and ways to channel out those conflicts in a healthy way. And no one is better to talk about the treatment of non-epileptic seizures than the world expert on treating non-epileptic seizures and the psychiatrist and neurologist, Dr. Kurt LaFrance.
The mainstay of treatment for psychogenic non-epileptic seizures is a psychotherapy. There are different types of psychotherapies, talk therapies. Some people have benefited from the use of cognitive behavioral therapy. Other people have benefited from an intervention that we developed called neurobehavioral therapy. Neurobehavioral therapy is a 12-session time-limited 1 hour per week intervention where an individual obtains the seizure workbook, taking control of your seizures workbook. They complete all the information. They take that completed information for that session to the seizure counselor, and they talk through the work that they've done. Over the course of those sessions, they learn how to identify some maladaptive coping that they might have learned, and they learn how to change that maladaptive to an adaptive or healthy coping. And they use those tools to increase their quality of life and their functioning, and to reduce some of their comorbidities like depression and anxiety, and to reduce some of their seizures. And we use that for epilepsy and for non-epileptic seizures. As we talked about, the comorbidities are very common in this population. And so not just focusing only on the seizures is, the treatment is not just focusing only on the seizures. The treatment also involves looking at the comorbidities like depression, like anxiety, like PTSD, like sleep problems, pain problems, cognitive problems, family dysfunction. So it really does take looking at the whole person biopsychosocial, spiritual, all of the elements of their humanity, so important to take care of the whole patient.
Regardless of the access to an highly experienced therapist, now we can use this book by Dr. Kurt LaFrance, which is Taking Control of Your Seizures. And this is a workbook, literally the cookbook for non-epileptic seizures, that will take you through 12 sessions. Every week, there is one session with homeworks and things that you do at home and discuss with your therapist, and will make every therapist a highly experienced therapist in non-epileptic seizure treatment. So you can keep your therapist that you like locally, and you don't have to travel far distances, because the psychotherapy needs like very consistent work, and you can make your therapist, if you guys follow the treatment workbook, it will be a great results. And the other thing is that with this non-epileptic seizures, control of seizures for patients, there is a version for the therapist. And there is that therapist guide that you can see here. And I will leave links in the description below of all of those books so that you can buy them and use them in your therapy. And those will help the therapist be experienced and how to apply the tools in the book and how to be very successful at administering this very helpful treatment. It's very important to notice that opening those wounds and going back to the painful trauma that happened takes a lot of emotional energy, and sometimes the patient is not ready to go there yet. And the experienced therapist will delay talking about those until they have good communication and good trust with the patient, and then they will talk about that later. And in this book, it was designed to do so. And they will first talk about mastering relaxation technique and mindfulness and insight on all of that. And then up until week number 9, when they start talking about the trauma and bringing this back. If we open the trauma too early, we bring something that we are not ready to deal with, and that can be counteractive, and that can worsen things rather than improving it. So it's very important to open things on the right time. So never do this. Like say from the first visit, hi, how are you? Tell me who raped you and what happened. And that is like very bad. Don't do that. Don't talk about it. I know that this is like the elephant in the room, that you want to talk about the trauma, but delay this until later. And that is much better results. And because this therapy is very successful, now, if your doctor is not experienced in non-epileptic seizures, I mean, lots of doctors, even epilepsy specialized doctors, they're not experienced in non-epileptic seizures, and they hate this diagnosis. Why is that? Because they don't know what to do. Like in cases of epilepsy, they give medication, they do surgery, and they kind of like, they see the biomarker, they see the EEG changes, and they feel comfortable with that. But with non-epileptic seizure, you have to understand and explain things, and that can be difficult to the regular neurologist, and they sometimes avoid that and don't follow what up with the patient. But here's the thing: if the neurologist, any neurologist, follow this book, gives you the book with the therapist, then you can be successful in treating it, and every neurologist will be a good neurologist for non-epileptic seizures. And the other parallel thing that we always have to do, which is treating any underlying conditions such as depression, anxiety, and PTSD. And the treatment of that can be therapy, also it can be medical management and medications, because there is imbalance in the chemistry in the brain and in the networks. We need to replenish the chemistry and restore the balance, and this can be done with medications such as the family SSRIs, selective serotonin reuptake inhibitors, or antidepressant, and such as like escitalopram and fluoxetine. All of those medications can be helpful, or SNRI, they help both anxiety and depression together, such as duloxetine and Effexor, duloxetine and venlafaxine. All of those medications are very helpful. They can be done in parallel. And then the studies have shown that if we combine CBT along with SSRIs, the results are much better, and we have better control of non-epileptic seizures. All right, if we apply the treatment, what is the success rate of this treatment? Well, here's the thing. People in the non-epileptic seizure, they will fall into one of the 3 categories. The first category, which is about 1/3 of time, they will stop having non-epileptic seizures completely once they know the diagnosis. So sometimes the worry of having epilepsy or having like a weird condition or having something bad in their mind is like really stressful, adding up. And once they know that this is not epilepsy, this is non-epileptic seizures, then they will stop. And I have seen it in multiple patients. The second third is that people will have the diagnosis, and then you give them treatment, psychotherapy, and then if they are invested in the treatment, treatment and they apply the homework and they work with the workbook, they can get better. And about the third of patients, then they will get better and seizures will stop. And there is a third, like 30%, they will have a resistant non-epileptic seizures. And they will keep having those in and out and keep having them even with the treatment.
We found actually in our studies that there are three characteristics of patients who don't improve. And not everybody is going to improve, unfortunately. That's the case with any of our interventions in medicine. As you know, people who take anti-seizure medications for epilepsy, 60% of patients actually have significant reduction. That means that 30 to 40% don't with medications. So just like in epilepsy, with non-epileptic seizures, not everybody gets better with the intervention. The characteristics that we found are that one, there are what we call characterological issues or personality issues that may be more deep or inherent that need to be addressed. How people view themselves, how they interact with others in the world around them. So looking at it from a group therapy or a family therapy perspective might be helpful, not just the individual therapy that I described. Another area is when some people have a history of acute or remote trauma that maybe they're just not ready to deal with. And so you can't force somebody to go to a place where they're not comfortable. So in time, maybe they will be able to approach some of those difficult areas. So trauma-focused therapy might be another way to help. The other characteristic of people who we see who don't have improvement are if there is ongoing significant family discord. So I tell people they're not just an individual operating in isolation. They operate in the context of a family system. So if they're going home to the same stuff, then again, bringing the whole family in might be something that can help to address some of those transactional patterns between the family.
One question is that, can I have epilepsy and non-epileptic seizures at the same time? Well, the answer is yes. You can have non-epileptic seizures and epilepsy in the same patient at the same time. And this is rare, though it can happen only in 10% of the time. And patients will know what is epileptic and what is non-epileptic. And sometimes we bring the patient to the epilepsy monitoring unit and record their events to differentiate which one is that. Because we will need epileptic treatment and epileptic medications for the epileptic seizures, and we need psychotherapy and other treatments for non-epileptic seizures. So it is different treatment. And sometimes we have cases of successful epilepsy surgery and then emergent of non-epileptic seizure, and about like 4% of the time this can happen. Other treatments can be such as EMDR, and motivational interviewing has been very helpful in patients. That can be done with their own doctor and neurologist. All of those can be other like psychoanalysis and psychotherapy. There are multiple other treatment modalities and psychotherapy sessions, and especially like maybe like trauma-based therapy. All of those can be helpful, and it is case-based between the neurologist and the psychologist and the psychiatrist, which is the best treatment modality to follow. One important thing to understand that not all events of fall or loss of consciousness or so with normal EEG, it means psychogenic events. There are sometimes events that are not psychological and they are not epilepsy. And there are multiple other things that are mimickers of seizures or look like epilepsy, but they are not. And some of them are physiological, heart-related, or other sleep disorders, or multiple other things that I explain in details in this video for all the things that look like non-epileptic seizures, but they're not. And stay healthy and see you in the next one. Salam.